Hi, Dr. Teplinsky. Welcome to MD Newsline. Thank you so much for joining us. Can you please introduce yourself to our audience?
Thanks so much for having me. I'm excited to be here. I am Dr. Eleonora Teplinsky. I'm a breast and gynecologic medical oncologist at Valley Health System in New Jersey and a clinical assistant professor at the Icahn School of Medicine at Mount Sinai.
Thank you so much. So we're here at ASCO, and there's a lot of exciting research and insights being shared. And I just want to know, what are some of the top insights and announcements that you've heard here at ASCO?
This has been a big meeting for breast cancer, and really the main updates have been in metastatic breast cancer. And there's really three big studies. There's others, of course, but there's kind of three big studies that everyone is talking about, and they're in hormone receptor positive, HER2 positive, and triple negative. So we can certainly break those down a little bit.
I'm trying to remember the title of the Serena-6 trial,
Yes.
right?
So yeah, we can start with that. That was a plenary. So, big study also published simultaneously in the New England Journal of Medicine. So the Serena-6 trial, what that does is patients with hormone receptor positive, HER2 negative metastatic breast cancer in their first line therapy with an aromatase inhibitor and a CDK4/6 inhibitor. And what they really asked in this study was, normally we wait for disease progression on imaging to change therapy. And they said, well, what if we test for ESR1 mutations early and change therapy before we see disease progression on scans? What is that going to do with the outcomes? So they had their patients, again, had to be on first-line endocrine therapy for at least 6 months. And then they were randomized they entered the study and they underwent screening for an ESR1 mutation via a liquid biopsy. For any patients, that is a blood test. And they did that every 2 to 3 months on the study, and they screened over 3,000 patients, and they detected ESR1 mutations in kind of around 550 patients around there, and about 350 were randomized. So once they detected the mutation, if they had no progression on imaging, they were randomized to either continue what they were doing, so continue on the AI and the CDK4/6 inhibitor, or switch the aromatase inhibitor to camizestrant, which is an oral SERD, a selective estrogen receptor degrader that's going to overcome, we think, the ESR1 mutation. And they continued on the same CDK4/6 inhibitor. So think of this really as an early switch approach before we see progression on imaging. And primary outcome was progression-free survival. And they showed that the median progression-free survival in patients who stayed on their treatment was 9 months compared to 16 months in patients who switched, translating into a 56% reduction in the risk of progression or death. So obviously this is really exciting, but there's certainly several concerns that, come up, right? So the first is camizestrant is not yet FDA approved, so that's, we can't use this. It's not something we're going back to the clinic and doing tomorrow. What is going to be the cost of these tests, right? They did them every 2 to 3 months. If camizestrant is approved, right, we think we'll have some guidance on cost and coverage, but what's, in this study, they did it every 2 to 3 months is, what's going to look like that in clinic? Are we going to do that every 2 to 3 months? Is it going to be less frequent? What is the right cadence? And so those are big concerns. And of course, we don't have overall survival data. We don't have PFS2 data. So what happens after that second progression? Because, the question that's been raised is, are we just switching earlier and delaying the progression? And would you have the same outcomes if you just crossed over and switched to camizestrant at time of progression? Or are we really impacting long-term survival? And so those are all still questions that we don't have the answers to. And in terms of side effects, camizestrant does have some side effects: anemia, neutropenia, some GI toxicity, joint pain, back pain. It can cause bradycardia, photopsia, dry eyes. The rate of discontinuation was very low, it was 1.3%, but and in the study they did show a decrease in the median time to deterioration of quality of life, an increase, so the more improved quality of life. But I think that there's still a lot of questions that remain, and we'll see what happens and as more data comes out, but really exciting. And I think really a novel approach of starting to look at this utilizing liquid biopsies, thinking, can we intervene before we see disease progression? And only time will tell what that really looks like.
Yeah, it's interesting. I'm wondering if they had any specifics on the demographics of the patients in the trial. I'm thinking about some of what we've heard about epigenetics when it comes to different people with similar breast cancers reacting differently to treatments, especially I think with the CDK4/6 inhibitor.
I think that's a really good question. Only 2.5% of the patients approximately were Black. And so that kind of limits, again, the applicability to more diverse populations. And I think that really also highlights, the issue that we have with enrolling to clinical trials, right? And the importance of enrolling a broad population so that we can take this to the clinic, right? And say it's applicable, because you're right, there are racial disparities and differences in outcomes by race that are much more than even socioeconomic, and social determinants of health, right? And things like epigenetics. And so I think that will remain to be determined, but that does kind of limit a little bit of the study.
Yeah. So there are two more trials. Tell me about the next one that you're super excited about.
So let's talk about the ASCENT-04 trial. So this is triple negative breast cancer, also first line therapy. So current standard of care, newly diagnosed metastatic triple negatives, we check for PD-L1 mutations. If PD-L1 is we check for PD-L1 expression, and if PD-L1 is positive, then patients get chemotherapy with pembrolizumab, and if PD-L1 is negative, they get chemotherapy alone. And there's a number of studies kind of trying to look at different agents here. And so what ASCENT-04 did was for PD-L1 positive, patients either received chemotherapy with pembrolizumab as the control arm, or randomized to receive sacituzumab govitecan with pembrolizumab. And what they showed in this study was that progression-free survival was improved with sacituzumab compared to chemotherapy, from 7.8 months in the control arm to 11.2 months with sacituzumab, really translating into a 35% reduction in the risk of disease progression or death. And I think this study is really important because we know that patients with metastatic triple negative breast cancer, we need better outcomes. We need to improve survival. We don't have, all the survival data here yet, but I think this one is a really important one, and certainly, is being considered practice changing.
I want to talk a little bit about cost before we get to the third one, because insurance is always such a big issue. In your practice, just looking at I don't know how many new treatments are coming out every year for breast cancer, not a ton, with approvals and things like that needing to happen. But when it comes to navigating either drug shortages, insurance landscape, what has been your experience and how have you navigated that?
I mean, I think it's a really big concern. I'm glad you asked about that, right? It's very easy for us to sit here and say, well, this is practice changing. But if I go back to the clinic and I try to get this approved for a patient, insurance is going to say, well, that's not the current indication for sacituzumab, which it's not. And will they pay for it? We don't know. I think we're seeing really significant, coverage issues and cost issues, denials. And, a couple of years ago, we dealt with chemotherapy shortages, and, these things directly impact patients. And so sometimes there is a delay, or often there's a delay between the data and the insurance coverage of these drugs. And I think it'll remain to be seen about what happens as we start to use maybe some of these based on the results of this meeting in the clinic, and will we get coverage? And that is really hard for patients also to hear, that you have this medication that has been shown to be beneficial, but it's really expensive and your insurance won't pay for it.
How do you see the role of antibody conjugates evolving, or what do you kind of hope to see us focusing on in the future?
Yeah, I mean, I think it's a great question. Antibody-drug conjugates have really revolutionized how we treat breast cancer. And what's happening is we're moving them into earlier and earlier lines of treatment. So with TDXD, with sacituzumab govitecan, right, their approvals and everything kind of are in later lines of metastatic breast cancer. So now we've seen them here in first-line metastatic breast cancer, and there are some studies now that we've had some press releases, some being presented, of moving them into the neoadjuvant setting, or early stage setting. And I think as that evolves, it really raises a lot of questions, and we're managing side effects, we're managing cost, of course, and benefit. And I think it's a really evolving field about, and it raises the question too, well, if we're using them early, we want to make sure that we're really improving outcomes, and can will the data show that by using some of these medications earlier, are we improving outcomes and reducing the development of metastatic disease? So time will tell, but I think we're really in an exciting time right now with a lot of change, a lot of transformation in the practice.
I'm wondering, with the use of technology, things like machine learning and AI, being used to both analyze past clinical trials and also being implemented just in real time, what we're finding, as we mentioned, with mutations and epigenetics, personalized medicine is getting really dialed in.
Mhm.
How do you see that or hope to see that evolve in the future? And as far as applicability goes, we have this kind of hesitance to join clinical trials across different demographics. So how do you see the role of technology? How do you see the role that technology plays in all of this?
Yeah, I think technology is here, right? AI is here, whether we want to use it or not. And I think we have to figure out how to work with it and how to use it to our advantage. And I'm hoping that, one of the things that will evolve is really evolution of that personalized medicine, right? Being able to understand who really will benefit from a treatment, right? Based on biomarkers and genetics and understanding which population truly needs and where we can escalate, where we can de-escalate. And I think, these have been some of the questions too that have been raised with the presentation of these studies and we'll talk about this with Destiny Breast 09 next, but does everyone need that regimen? Or can we start to figure out based on certain mutations of the tumor, based on extent of disease and disease burden, who needs it? So it's coming, but it's going to take some time.
Great. So yeah, that leads us to our next trial.
Yeah, so Destiny Breast 09. So this one is for HER2 positive metastatic breast cancer. And the standard of care for HER2 positive metastatic breast cancer has been unchanged since 2012. So for 13 years, we've done the same thing. We've done a taxane with Herceptin and Perjeta. And after a certain point, we can drop the taxane if the disease is stable and continue on Herceptin and Perjeta as maintenance. And if you're hormone receptor positive, we add in endocrine therapy. And in the San Antonio Breast Cancer Symposium just this past year, we saw the Patina study, which looks at adding a CDK4/6 inhibitor to endocrine therapy. And so now we have the Destiny Breast 09, which looks at TDXD, which is an antibody-drug conjugate, trastuzumab deruxtecan, in first-line metastatic breast cancer rather than in subsequent lines that we currently do now. So in the study, they had 3 arms. They had TDXD alone, which is not presented in this analysis, TDXD with Perjeta, and THP. And what they found was that TDXD with Perjeta improved progression-free survival from about 26.9 months to about 40 months. So improvement in progression-free survival. And the challenge here is that, again, does everyone need it? Because you have to think about side effects. We have to think about with THP, we can drop the taxane, and Herceptin and Perjeta, people can continue on that. Whereas here, they're continuing on TDXD. We have to think about the long-term side effects, the risk of interstitial lung disease, which is about 12%. And where does endocrine therapy fit in, right? And where does the Patina study fit in adding that CDK4/6 inhibitor? So there's still a lot that needs to evolve in this study. They did find that there was a higher proportion of patients with TDXD plus Perjeta that had a complete response. And in the discussion today, they raised the question, which I think is what we're all thinking is there going to be a point where we kind of do an induction with TDXD and then maybe switch to HP as maintenance? And there is an ongoing trial to answer that question. So I think great information raises questions about what is that going to look like in the clinic? Is it for everyone? Are there certain subsets of patients that might benefit? And so this is our first analysis. So there's going to be things that evolve and trying to figure that out and really talking to patients about goals. And I think so great information. I don't necessarily think that everyone's going to get TDXD with Perjeta right now, but who knows? I think it's going to evolve. And again, it comes back to insurance and cost and whether it will be covered. And again, we always have to think about side effects and what living with metastatic breast cancer really looks like, and how do we help our patients do it the best that they can.
And I just want to touch on kind of some of these side effects just a little
Mhm.
bit, because these are the conversations that really change or should change or impact how a patient decides to go about course of treatment. How are you having these conversations about, like, let's say the cumulative toxicities of some of these, like the CDK4/6 inhibitors and things like that, versus conversations about, the risk of interstitial lung disease? How are you kind of handling those conversations? And are patients making kind of different decisions about treatment, or is it just kind of a good to
Yeah.
know?
No, I think people are, right? And I think it takes time. And it's not a one-time conversation. I think sometimes we have to come back and we have to think about it. And I always say to patients, I want you to go home and do your research and think about it. And then you don't have to make a decision today. But I think it looks at what are the patient's underlying medical problems? What is their medical history, right? That's a big part of it. What are their goals in treatment? And understanding that we can dose reduce when we need to. So sometimes patients, we want to make sure we're open about that conversation. We're going to start at this dose. And sometimes for certain drugs, we'll start at a lower dose and, escalate. We saw some data at this meeting about early stage breast cancer, but using abemaciclib, which is a lot of GI side effects, and doing a dose escalation rather than starting at that dose and working down. But, over time, over a period of weeks, increasing the dose. And that actually seems to be a really feasible thing that we can do. And so really working with patients about side effect management. I think one of the challenges is that, you know, when someone says, well, the side effects are well tolerated, right? Well, what does that really mean? Because for each patient, well tolerated is different. For a patient, 1 or 2 episodes of diarrhea may be too much. If they are not sure when it's happening, they can't leave the house. On the other hand, some people are okay with that. So it's really that focused conversation about priorities and side effects, and understanding too that once we start something, we can pivot, we can adjust, we can really, but it's an ongoing conversation.
What are some practical considerations out maybe outside of cost? I'm thinking about like location, and things like that, as far as getting back and forth to clinic. What are some things that you hope that research considers in the future that may be being missed now?
I mean, I think really thinking about time toxicity, right? How much time are patients spending in the infusion chair, or, at visits? It's a lot of time for doctors' visits, and then all the ancillary tests that come with being on treatment, right? Blood work and scans and echocardiograms and all of that. So I think, I would love to see us focus on that, right? In terms of really thinking about how do we truly improve the lives of patients living with metastatic breast cancer beyond the therapies, right? But in terms of all of the other things, support, caregiver support, patient support, all of those things are really, really important. And I think we've really come a long way. But we still have a long way to go.
With the evolution of a personalized medicine, and with lots of things are multifactorial, right? And we have our
Yes, of
genetics,
course.
we have our environment, we have our lifestyles, and so many things. There's a lot of need for interdisciplinary conversations.
Mhm.
Um, um, how do you hope to see interdisciplinary conversations happening among doctors? I think of conferences like ASCO and conferences like San Antonio Breast Cancer Conference and others, and I don't see a lot of bridges between specialties, but it seems like with the way that medicine is evolving, especially with machine learning kind of picking up insights, that there need to be more conversations between specialties, but there doesn't seem to be enough time in the world to do it. Do you have
Yeah.
any thoughts on how we can kind of bridge those
Well, I
gaps?
think it's really important, and part of that is, with a lot of the novel therapies, they have side effects, and some of them have visual side effects. So we got to bring in our optometrists and ophthalmologists, and some of them have, high blood sugars. We got to bring in our endocrinologists, and so forth it goes. And so it really is a multidisciplinary team, not to mention just people within the cancer center, our surgeons, our radiation oncologists, our dietitians, social workers.
Mhm.
palliative care. I mean, I'm leaving out so many people, but the idea is that we all have to work together with the patient as the center, right? And then everyone kind of surrounding that. And that can be really hard because, as you said, we're busy. And I think we just chip away at it little by little. But for patients, I always urge them to understand that it's a big team, and not to be afraid to ask their oncologist, to have those conversations, right? Because I think it's so multidisciplinary, and ASCO brings together a lot of people, which is amazing. And I think as it grows, we'd like to see more, again, that ancillary, those people that are also part of it. But we have we have great, I've seen some palliative care here people and nurses and social workers, a lot of patient advocacy organizations, but it will take time.
Yeah. Well, it's been great talking to you. Thank you so much for joining us on MD Newsline.
Thanks for having me.